Okay, and we're live. So, welcome to the TRT and Hormone Optimization YouTube channel. And we have a new guest today. That's Dr. Chris Bronson. Welcome, Chris.
Well, thank you for having me. Appreciate it.
You're welcome. So, since it's the first time, maybe let's start by letting you introduce yourself.
Sure. So I'm a board certified internist, medical doctor in the U.S. Practice primarily in South Dakota, but I'm also in several other states through telehealth like Florida, Georgia, Pennsylvania. There's a number of states, not all the states, but a number of them. What I primarily focus on is a treatment is TRT, but primarily using TRT in men with metabolic syndrome. So metabolic syndrome will be middle-aged men who are obese, but more than just being obese, they have like high blood pressure, dyslipidemia, one of a number of other chronic diseases that an internist would typically treat. And we use testosterone a lot of times to help treat that problem in part. Most of my patients are obese and have metabolic syndrome, but a lot of them also are hypogonadal. You know, it's about 40 to 50% of men who are obese also have low testosterone levels. And so it's not always like we give people testosterone with normal levels. We do that, and we're experts in doing that. However, I do have to say most of my patients definitely meet the traditional criteria for low T, but that's my practice area.
Mm-hmm. Interesting. And maybe the first question, is being overweight a risk factor for being hypogonadal as well?
Yes, it is. Especially if we now know there's a few different types of obesity. The most common type, the one that accompanies aging, is where not only do you, as you age, you lose muscle mass, you lose skeletal muscle, and you gain subcutaneous fat. And we see that, you know, our pinchable fat, our faces get fatter, our necks sag, whatever. That's a problem. But the biggest problem is you gain fat around your internal organs called visceral fat. Visceral fat is an endocrine organ, actually. It secretes chemicals into your bloodstream that can cause a chronic low-grade inflammatory state. And when you have obesity plus this chronic inflammation caused by the obesity, at least directly or indirectly, that's what we call metabolic syndrome. And a huge percentage of people in the US have metabolic syndrome. And now I'm forgetting what the original question was because I'm going off on my lecture.
If being obese was a risk factor
yes.
for low T as well.
Yes. So what happens is when you have metabolic syndrome and you're obese, this chronic inflammation interferes with your testosterone production, sometimes directly. For example, some of the chemicals released by visceral fat, which are called adipocytokines, have a pro-inflammatory effect on parts of the brain. For example, your hypothalamus, which releases something called GnRH, which tells your pituitary to produce other hormones called LH and FSH. The LH and FSH obviously tell your testes to make testosterone. And the inflammatory state of obesity can actually interfere directly with that circuit at multiple different points. But increasingly, what we're also finding out is not only does, when I use the term obesity, what I mean is metabolic syndrome, because I said there's different types of obesity, but okay. So what we're also finding out is obesity is also accompanied by this chronic inflammatory state that can interfere with your androgen signaling, is what it looks like too. So you can have a situation where men have so-called normal levels, but their androgen signaling is very inefficient for multiple cellular reasons, mostly mitochondrial reasons. If people don't know what mitochondria are, they're parts of just about every cell in your body that generate energy. And a big part of the way that testosterone works is by modulating those. You can think of them as engines, okay? And and it does so in beneficial ways. It can do so in certain contexts in not so beneficial ways. But yeah, the answer to the question is, does obesity predispose you to low testosterone? Yes, not only does it predispose you to having low testosterone levels, it predisposes you to having, for lack of a better term, a situation where your testosterone doesn't work as efficient. What you do have doesn't work as efficiently as it should, if that makes sense.
Yeah. And concerning treatment of those guys, will putting them on TRT help with the obesity, or will you first make them lose weight so it will help for the testosterone?
So when you say those guys, do you mean just specifically obese guys, or
Obese
obese
guys
guys with normal
with low,
levels?
yeah, obese guys with low T already.
Oh, with low T already? Yes. So there's multiple studies that show this too. The testosterone helps in many ways. The way that's probably most relevant to the audience is, what are the most common drugs used to treat obesity these days? Well, that would be things like semaglutide, tirzepatide. Some people use retatrutide, which is not, approved in the US yet. Those drugs are pretty effective, right? The problem is they cause a lot of muscle loss because people end up losing a lot of fat, but they lose a lot of muscle. If you lose a lot of muscle when you're losing weight, that's not good, because it actually lowers your resting metabolic rate to lose muscle tissue. Most of your glucose being blood sugar, is utilized by your skeletal muscle. So the idea is, if you're obese, yes, you want to lose fat, but you want to lose fat without losing muscle. So the TRT does several things in addition to drugs like GLP-1 drugs. It helps preserve muscle mass while you lose fat. It also accelerates the fat loss because testosterone has very potent effects on pathways that affect lipogenesis and handling of blood sugar and insulin sensitivity especially. So what I would say is, yes, it does almost always help, and in men, especially with low testosterone levels, it's pretty profound.
So you don't make them lose weight first, and you say TRT will be the cherry on top. You start them on TRT at once.
What I do is I start them on 4 things. First thing is resistance training. Some type of weightlifting is extremely important. The second thing is, yes, diet, but especially we want to have a protein intake that's targeted towards muscle gain. And the third thing we do is something targeted towards the obesity, which is in the vast majority of cases semaglutide, tirzepatide, whatever. And then, if I think it's going to be beneficial, in many cases it is, then the testosterone comes on top of all those things. One thing I don't do is I don't put people on TRT if they're not willing to do at least the resistance training and the diet modification. Okay. Just being fat and being on TRT and just sitting on your couch is going to be, I guess, if your testosterone levels are very low, you may have some cognitive benefits from it, but medically speaking, you're not going to benefit anywhere near as much from it. And there are many studies. The most famous one is something called the T4DM study, which was published in the Lancet, I believe, in 2021 or 2022. And this study showed that even in men with normal pre-treatment testosterone levels, on the lower side, but still fall within the normal range, if they do a resistance training program plus testosterone, compared to men who do just resistance training and no testosterone, they have about a 40% decreased risk of developing type 2 diabetes, which is actually higher, a higher rate of, there's probably a better term for this, but a higher rate of not getting diabetes than if you use the diabetes drug called metformin. So metformin is commonly used in patients at risk of diabetes to prevent them from getting diabetes. There's a few studies now that show that TRT actually works at least as good as metformin, probably even better. And how does it work? Number one, it increases your skeletal muscle mass, which is what helps with the glucose control long term. That's not a short term effect of TRT. And it also reduces your visceral fat. Remember when I was talking about the fat around your internal organs, visceral fat, there's very few drugs that reduce that. GLP-1 drugs looks like they can reduce it, but we've known for a while that testosterone also reduces visceral fat. And it's very interesting how testosterone does that because it involves estradiol, okay, which a lot of guys are a little bit confused about. But yeah, that's essentially the answer.
Thanks. All right, maybe up to the next point, let's talk about some TRT myths or stories that are being told about testosterone being dangerous or causing side effects. Maybe let's talk first about blood donations. I know Justin already has made several videos about blood donations. What's your stance on it? Do you ever have patients having to donate blood?
You know, I do. It's not many. It's probably about, 15 to 20% have an issue where they have to donate. Over time, usually we can get that down. In other words, even people who initially have to donate a lot, over time we reduce or eliminate the need for that. There's a huge controversy right now that spans. One side of it is if your hematocrit, or the percentage of your blood cells that are red blood cells, which testosterone increases, if it gets even a little bit high, okay, normally in men, roughly about 40 to 50% is considered normal. Okay, it changes from lab to lab. But there are some doctors that think, okay, it's 51%. That's really dangerous. We need to immediately get this patient phlebotomized. We need to remove 1 unit of blood. Removing 1 unit of blood, they always taught us in residency about drops your hematocrit about 3%. And so that's what every patient needs. The second it's even 50.1%, they have to go immediately to the hospital, not the Red Cross. They go right to the outpatient infusion center, and we remove blood. Even if it's a Sunday, we have to do it. Okay, that's one side. The other side is, who cares? Don't even check it. Doesn't matter. It's not dangerous. Why do they think it's not dangerous? Oh, well, look at all these people that live above 5,000 feet. Okay. The Black Hills of South Dakota, I think Rapid City is like at 5,400 feet or something like that. A lot of these patients, especially if they live on a mountain in Rapid City, their hematocrit at baseline is already high, above average. Okay. They don't die of blood clots, is what these proponents say. And so probably it's fine. Okay. Because what used to be, we used to in medicine call anytime your red blood cells got high something called polycythemia. It turns out that that's not the correct way to use the term. Polycythemia really means an increase in platelets, usually your white blood cell line and your erythroid lineages too, so your red blood cells. However, the correct term for when it's just your red blood cells is erythrocytosis. So there are certain diseases, certain cancers of the bone marrow called myeloproliferative neoplasms. The most common one, and you'll understand once I say the name of this disease, if you're an audience member, why it gets confused, is called polycythemia vera, which is a condition where, yes, your red blood cells are increased, and yes, you have a very high risk of developing blood clots. In fact, last I read, 40% of people with polycythemia vera are not even diagnosed until they have a blood clot. So they go to the hospital, they get diagnosed with blood clot, they do some genetic testing, whatever. Now we know you have polycythemia vera. Okay, so using those terms interchangeably for many decades has just mistaught a lot of doctors in thinking that red blood cells going up is the same as this other condition that is highly associated with blood clots, and it's not true. So those are the two extreme sides. Is one, you have to treat everybody like they have bone marrow cancer, and the second it gets even a little high, you have to either stop it or phlebotomize them. The other side is, don't even check it. It doesn't matter. It's not dangerous. Never been proven to be dangerous. I'm in the middle of those two. Okay. I have a pretty high target for phlebotomy. I think it should be around 55%. I think it should be, there's a reason why I have a target of 55% that I could explain it if you're interested. But that's what I use. So that gets me around 20% of people. And also another big thing we do is we check iron levels every 3 months. You know, we don't let people donate if they're already iron deficient, or we replete their iron at the same time, or what. We have some strategy, because what does happen a lot is people go to TRT clinics. They're told, hey, you got to go donate blood every 2 months, regardless of what your hematocrit is. And they end up becoming iron deficient without anemia, which is possible. It's possible to be iron deficient and not have anemia, which a lot of guys don't understand. So some guys feel bad on TRT, not because of the TRT, but because of all the blood donation has depleted their iron stores. That I wouldn't say is super common, but it happens with fairly high frequency.
Mm-hmm. I know a lot of men that will see this video later, they will ask why the 55%? Again, it's a number. Why 54 okay and 55 not okay?
So the reason why my target, again, this is like an opinion thing. It is not like I have so much data and this 55 is so much better than 54. It comes from the Hematology Society guidelines. When I say society, various international society guidelines on when you should phlebotomize someone with chronic hypoxemic lung disease. So if you have what people commonly refer to as emphysema, let's say you were a lifetime smoker, now you have emphysema, or what should be called COPD. A lot of times you develop high red blood cells, okay? The concern anytime your red blood cells get high or your hematocrit gets high is that your blood clot risk is higher, okay? That's never really been proven in anybody but those bone marrow cancer patients I just told you about, which they have reasons other than just their red blood cell count for why they have an increased clotting risk. They have platelet issues. They have tumors that secrete various things that promote blood clotting, that people with just as erythrocytosis don't have. So what happens with these chronic lung disease patients is they get phlebotomized, but at a 55% or above target. It's a high target because, again, we want to balance the number one risk of iron deficiency. Chances are their stimulus for continuing to get erythrocytosis is still going to be there. They're still going to keep smoking. In the same way that someone on TRT, the stimulus will still be there. The way that smoking induced erythrocytosis or lung disease induced erythrocytosis, those mechanisms, and with TRT, they're not exactly the same, but it's the way that testosterone increases your red blood cells is definitely not the same as the way these bone marrow cancers increase your red blood cells. So I think it's a good balance between just like careful caution and recognizing that we don't fully understand the risks of high hematocrit. Certainly hematocrit that is a standard deviation above the normal range. There's not a lot of studies. There are some studies in people with high altitude induced erythrocytosis that shows, they don't have an increased clotting risk. But again, the mechanisms are not the exact same. So it may be the case that in the future we find out there is no risk. It may be in the future we find there is a risk. But I think after 80 years of treating people with testosterone, it's better to just balance between, in areas where you don't fully have all the information, settle on something reasonable. Mm-hmm. You don't need every patient to go donate blood every 60 days. That is incredibly overdoing it. At the same time, do you just ignore it? I don't know that medico-legally it's impossible to do because people will get blood clots. Okay. And if they get a blood clot and they're on the testosterone is going to be blamed.
Yeah.
Even if they had a total knee replacement a month prior, which is highly associated with blood clotting risk. Mm-hmm. That's just the way it goes. So it's a mixture. Where I arrived at, it's a mixture of practical concerns and balancing a lot of unknown risk. And to be perfectly honest, since I'm known for being very blunt, medico-legal concerns. Because I don't want my patients going to their primary care doctor and then being like, what the hell is it? Your hematocrit 62%? and no one's checked it in a year,
Yeah.
that makes you look really bad.
Mm.
And that's just the truth. That's part of the consideration too.
Yeah.
Now, that being said, do I have physician patients that say to me, yeah, I know my hematocrit's 57 and I know you're going to tell me I need to donate, but F you, I'm not. And that's fine if it's their choice. That's
Yeah.
completely fine with me if they choose to do that. But that's where things stand, and that's kind of where I stand.
Yeah, agree. Okay, so maybe let's talk some practical things about TRT. Administration route. Do you prescribe the cream as well next to the injections?
So I think injectable sub-Q and injectable IM and compounded creams from a compounding pharmacy are about equal in terms of their effectiveness.
Mm-hmm.
Now, I do have to say with the compounded creams, you can't say it with super high confidence just because nobody studies compounded medications at all. But certainly compounded creams can get very high levels, and the cumulative experience of probably, many older doctors have been doing testosterone a long time. They prefer the compounded creams. So I think they're roughly equal. I prescribe all of them. Very few of my patients use the compounded creams simply for convenience reasons. Like they don't want to have to apply something to their scrotum and then not be able to have anyone come into contact with that part of their body for 3-4 hours. So that can be an issue, but does it work? Yes, it works very well.
Mm-hmm.
And I'd say my preference is sub-Q
Mm-hmm.
test. That's my preference. But is it better than everything else?
Mm-hmm.
No, I couldn't say that.
Why do you prefer sub-Q to IM if you start someone up on TRT?
I prefer, so the first thing is if someone comes to me who's been on testosterone 30 years and they've been doing IM for 30 years, I don't ever change them. Like, I'm doing good this way. Okay. People rarely come to me if they're doing good though. So that's the thing. I get a lot of patients that have been elsewhere. And so I have to fix stuff and change stuff. But I like it for new patients because number one, it's very easy to do. Sub-Q is very easy to do. There's pretty good studies that have compared sub-Q to IM and have you obtain about similar levels for the most part, and maybe even a lower side effect profile. We know, for example, from one study that patients who were switched from IM testosterone cypionate once weekly to sub-Q testosterone enanthate once weekly had about a 20% lower risk of significant erythrocytosis. Their total estrogen levels at trough were lower than the guys in the IMTC group and reported less side effects, but the benefits were all the same. They had the same body composition changes. And so my interpretation of that is people that are doing well on IM should just keep doing what you're doing. But for brand new patients who've never injected anything, I think sub-Q is a very easy, decent way to start. There are other doctors that disagree. They like starting different stuff. A lot of my friends in this business, they love the compounded creams, so they just like pushing guys onto that. I mean, it's not like they're wrong and I'm right. That's just what I find is the best.
I guess
This works best
sub-Q,
for me.
yeah, I guess sub-Q is easy for patients that are overweight.
It is. Well, they have a lot of belly fat and they have a
Yeah.
lot of fat on their flanks, and
If
that's the
I
thing
had,
is you want to have pinchable fat. So
yeah, yeah,
that can be an issue.
yeah. If I had to inject something sub-Q, I have a hard time finding anywhere of a layer
Yeah,
of
me
fat.
too. I can't inject into my abdomen because my body fat is too low.
Yeah.
But there's a little brag there. No, but yeah. So, but here's the thing: they've done studies with like MRIs on guys that give themselves IM gluteal injections, and they've actually put these guys in an MRI machine, measured the depth of where their muscle sits, and then taken the size of the needle And it was something like, I got to look up the study again, but it was something like 50% of guys were giving themselves a sub-Q injection unknowingly without any harmful effects. So that's why I say, you guys like, well, I'm using a blank size needle in my glutes. Is that too small? I'm like, it doesn't really matter, because even if it is just a sub-Q injection, it'll be okay.
Okay, so that's for administration route. So let's talk frequency. What's the frequency you start guys on if they're new to TRT?
Every 4 days usually, I think. And I start low on the lower side, depending on, like, I have patients, I have very sick guys. I have guys with like heart failure that get sent to me from cardiologists. I have very, older men with various heart issues and stuff. So sometimes I'll start as low as like 0.35 every 4 days. Okay. But for many men, I'll start at less than 100 milligrams a week. So like 40 milligrams or 35 milligrams every 4 days. Most patients get started at 50 every 4 days. But the way that we do things at our clinic, which is very different, is we don't worry too much about where your dose starts. 90% of patients, it's going to be 50 milligrams every 4 days. But 3 months after you start, not only do we check your labs, but we look at your body composition. Is your muscle mass increasing? Is your percent body fat decreasing? Okay, it's not. All right, then we increase the dose 10, 15, 20%, even in some cases. And we titrate to their body composition, because ultimately the benefits from testosterone medically long-term, I believe there's lots of evidence, come from what does it do to your body composition. If you're obese, you have metabolic syndrome, we need to cure the metabolic syndrome. How do we do that? We need to reduce your visceral fat. How do we know if we're reducing your visceral fat? Well, we can now measure that directly on DEXA scans. We can measure that mostly indirectly with like impedance scales and things that are not super accurate clinically, but the trend matters most. So body composition to me is extremely important. So people are like, that's too low of a dose, that's too high of a dose. You'd be shocked at the doses that patients can actually gain muscle and lose fat on. Some patients need very high doses. Some patients don't need that much. I even have geriatric patients on compounded cream, very low dose, and their body composition is excellent. They have no chronic disease. Their A1C is 4.8%. If I talk shit to them in a bar, they could probably beat me up, even at 90 years old, and they've been on testosterone sometimes for 20, 30 years. So everyone's different. The dose that, if you ask me, what's the dose most people start at? 0.25 every 4 days, which is equal to, if you're using 200 milligrams per ml, that'd be, 50 milligrams every 4 days. People be like, that's very low. Well, that's not the dose that 95+% of people will be at long-term. And since it's a lifelong treatment, it's not all that important where you start. What matters is that it's adjusted appropriately and that your body composition is included. Because what happens is that a lot of TRT clinics, they ask, oh, how are you feeling? Oh, your sex drive good? Oh, yeah, you feel good? Oh, okay, your levels. They look at how you feel. What are your levels? Nobody takes into consideration your body composition. And so there are a lot of patients that have been at TRT clinics for 3-4 years. And it's like, you started testosterone, your percent body fat was 35. Now it's 37. What has the testosterone done for you over the past half a decade? But like, in some cases, well, it's made my sex drive better. My erectile function's a little bit better. Yeah, but it hasn't done anything for your longevity and your chronic disease risk. So, I encounter that a lot. But that is the dose most people start at, but it is not the dose the vast majority of people stay at.
And what's the mean dose that people end
200
up
a week is about average. Some
yeah.
people, yeah. So, have people get up to 100 every 4 days. That I think is probably the most common.
Okay.
Eventually, and then I do have some bodybuilder patients that retire from using high doses of synthetic androgens, and we have to titrate them down. Because let's say you're using 1.5 grams of testosterone for a decade, which I've met guys that do that. People think, oh my gosh, there's no way you can do that. Trust me, there are people that have done it. You shouldn't do it. Okay. And it comes with a lot of problems, but there are people that do it. Okay. You can't take a guy that's using 1.5 grams and just, here's a 200 milligram a week dose. So a lot of times I have to, taper them down, but eventually they do get to a TRT dose. Everyone eventually gets to it, because when you're with me and I'm prescribing testosterone, it has to be for medical purposes, it has to do something positive. And if I think that the risks outweigh the potential long-term benefits, then we, don't do it. So that's the answer.
Okay. And what is your experience concerning the timeline of the TRT benefits that kick in? What benefits do you see your man get first, and what others later?
So I think, let me drink this real quick, because it's a little bit longer answer. But so for patients who are hypogonadal, it depends on what your symptoms are. If your symptoms, fatigue is the most common symptom of testosterone deficiency, or the most commonly reported one. So if you give men a checklist of, you have fatigue, constipation, sexual dysfunction, erectile dysfunction, low libido, the vast majority of men with true androgen deficiency will check fatigue, and they describe their fatigue as just a feeling of total exhaustion. That's the most common way they describe it. It's exhaustion that even if I sleep 8 hours a night and I have, good sleep hygiene and everything, and I'm not working 1 million hours a week, that's how they describe it. I'm totally exhausted regardless how much rest I get. So, the fatigue and cognitive issues associated with androgen deficiency should improve within a month or two, definitely within 3 months. Body composition, which, as I've explained, is very important to our practice, should change within 3 months. Okay. And what do I mean by that? I mean that your skeletal muscle mass, if you're very obese and you're losing weight, so you're in a calorie deficit, your skeletal muscle mass should not decrease too much. Okay. It should more or less remain the same. Ideally, it will increase. Your percent body fat, though, should decrease. It should be trending downward. That should happen within 3 months. Sexual symptoms, depends on what you're talking about. If it's like sex drive, that reliably does usually increase within 3 months. It's usually shorter. Some guys will notice a difference almost right away. Okay. Especially they've been living with low testosterone levels for a long time. Erectile function is a little bit more complicated. In theory, if the testosterone is going to help with your erectile function at all, should be within the first 3 months. Maybe it should help a little bit. Okay. So what said all that to say, usually the effects are fast, but everything that's beneficial you should notice a change within 3 months. That's why we follow up with people every 3 months. That's why we check people's labs every 3 months. And that's why we do body composition scans every 3 months, is because the 3-month mark is when you should feel and look different than you did 3 months before. And if you don't, then we have a problem. Either you're not doing something correctly, or most of the time we're just not at a correct dose, or, then we adjust things. But everything on a 3-month time scale.
Okay. And if men are optimized, what's your experience concerning their total and free T levels on which they feel good with all symptoms gone?
So this is something that differs for everybody. So as I go through that process where we're evaluating people every 3 months, eventually, yes, we do get to a point where your body composition is ideal for longevity. Okay, what is that? It's usually for men, a percent body fat, 15 to 20%. It's higher if they have heart disease. If they're totally healthy, maybe like 12 to 15%. There's some evidence that's the best. Okay. And then skeletal muscle, we want to be good. There's no exact target. We want it to be definitely above normal, not low. Right. Okay. So, and that's going to differ for everybody based on their, height, weight, genetics, things like that. So what do I do when all that body composition stuff is perfect? Well, what we try to target is a testosterone trough level of around 1,000. We do not use free testosterone targets. Why? Because the very limited long-term epidemiology is all using total testosterone levels, not free testosterone levels. And free testosterone levels are very useful for people who are not on testosterone, like determining, for example, when you put someone on TRT very early, their change in free testosterone is more predictive of better symptomatic improvement than their total testosterone level. Okay, so that is true, but that's on a short time scale. And then the other studies are looking at free testosterone in people who aren't diagnosed. So people who have normal total testosterone but low free testosterone, those patients can still benefit from TRT. So it's important to know that. When you've been on TRT for several years, your free testosterone, I don't think, is nearly as relevant at this current moment with the current evidence and studies that we have right now. So someone who's been on testosterone for 3 years, who I've helped get from 40% body fat down to maybe like 18, 20%. Okay, I'm not as worried about what their trough free testosterone level is as what their total testosterone level is. And the general target is about around 1,000, around 1,000.
Okay.
Now, the important thing to say, though, is that is not possible in most men. It's not possible to maintain adequate body composition and while also, of course, we want to limit side effects. Like we don't want, you know, if people are having side effects, we don't push their dose higher like right away. So assuming all that stuff is okay, some men have to tolerate higher levels just to maintain their body composition. And I found that what happens is I'll get a guy, okay, we've reached your body composition goals. You're on a low dose of a GLP-1 or maybe off the semaglutide or tirzepatide completely. But your total is like 1,400, let's say. Let's decrease the dose by 5 to 10%. Then 3 months later, everything again, all your labs, body composition. Now, when I do that the first time, they may come back in their levels 1,250 or something, but their body composition stayed good and they feel good. They don't feel any worse. Okay, let's try another 5 or 10%. Okay, 3 months later, everything is still good. They feel pretty good. And now we're maybe at 1,100. I have found with a lot of experience, if I try to do a third 10% reduction, more than 50% of the time, I'm going to cause problems. Their body composition is going to go the other way. They're going to start feeling not as good. I'm going to cause issues. So I just don't usually do it after 2. Okay. In patients that are really concerned about wanting to get to 1,000, which the vast majority aren't. But in ones who are, okay, then yeah, we'll cut again. The problem is once long term, once you go down and you start to feel worse and your body composition starts to worsen, a lot of times if I go back to your old dose, that won't even fully work. And I don't know if that's a mental effect or a drug effect. It's probably a combination of both. So yes, I try to target a total level of around 1,000. That's a trough level. So that'd be the day that you inject before you inject. So let's say you're injecting every 4 days. Okay, it'd be on the 4th day at the time you'd inject before you inject. That's what we look for. And like I said, and based on how frequently some people inject, it's also not possible even to get to that level. But, you know, everybody is different. And a lot of it is also a risk tolerance thing. There are some guys in their 60s, and I'm like, you know, your total testosterone level is 1,300. We don't know that that's safe. It could shorten your life. Maybe it's associated with heart attack, strokes 5-10 years in the future. I don't give a shit. I feel good. Just leave everything alone, please. For the love, just please leave everything alone. That's different than a guy who's 32, okay, who has hopefully many, many decades in front of him. We want to be more cautious, right? Because we don't technically have super long-term safety studies on TRT the way most people administer TRT.
One remark on your 1,000 total testosterone in the chat box. What about people with high SHBG? Simon says, I got on TRT when my total testosterone was 1200.
Like he started TRT when his total testosterone was 1200.
That's what he says, but he says when people have a very high SHBG, you can
Yeah.
get the PT will be low.
Yes. So when I say everybody, that's why I said everybody's different. You know, there are certain people with congenitally very high SHBG. What should happen is when they get androgens, it should lower their SHBG. 90% of the time it does, especially with like synthetic. Well, I guess testosterone's a synthetic androgen technically, but non-testosterone androgens, including many orals, will usually very potently lower your SHBG. That doesn't happen to everybody. And so, yeah, some patients have to have doses that are higher because their SHBG is higher, and that's the way it is. And I'm not sure if there was a question in what he said, but yeah, it's not like a strict thing like I was explaining. It's a very highly individualistic thing. Okay. I have a physician patient right now, for example. His total testosterone level is higher than 1,000. I'll just put it to you like that. His SHBG is very high. He's like, it is what it is. If you lower the dose, I feel terrible. So I guess we got to stay at this one. His doses still would be considered a TRT dose, but it's higher than the majority of patients. But that's an example of a doctor with, you know, so yeah, everybody's has to be treated differently. For me, unlike a lot of TRT clinics, I'm not like, how do you feel? Do you feel better today than the day you came in when we had this dose? I care a lot more about body composition. I do care about people's sex drive, libido, especially if those things are getting worse, but and work-related performance. I ask and I care about all those things, side effects, blood pressure, but body composition to me is where a lot of the money's at, because that's what's really going to move the needle for somebody. Okay. Giving somebody these lower doses of testosterone for years and, oh, maybe I feel a little bit better, but their body composition doesn't change. You're not doing much for them medically. I mean, that's like I told you, I had that guy. He started testosterone, body fat 35%. Now it's 37. Now, maybe it would have been much higher had he not been on testosterone. Almost guaranteed it would have. But you got to be a little bit more aggressive than that. We live in an environment that poisons us constantly in many, many ways. This is going to be what my second book is about, you know, environmental endocrine disrupting chemicals. The biggest one is our light environment that we live in causes circadian rhythm disruption. So it's unavoidable for men in our society to avoid things that tend to not only lower their testosterone levels, but promote metabolic disease in general. And you can see that just in the, just in the statistics, right? We used to have in this country a childhood obesity rate of less than 1%. Now it's about 20%. Okay. 5% of adults in the US had high blood pressure. Now it's like 50%, 120 million people. Okay. And then if you look at like just diabetes used to be 1%. Now it's like close to 15%. And 40% of people have what's called pre-diabetes. So in the span of 100 years, our society has gotten significantly sicker than what we were. Yeah. Do we have worse medical care today than we did 100 years ago? No, we have all this fancy technology. We have all these drugs. We have a variety of novel weight loss drugs and things like that. But the problem has slowly, not even slowly, the problem has pretty rapidly gotten much, much worse. And it's the environmental issues causing or promoting the metabolic syndrome. And then the testosterone issue is downstream of all the metabolic issues. The good thing is, it looks like from many recent studies that testosterone can help reverse a lot of the metabolic dysfunction that men are living under, and pretty safely, but with a lot of long-term unknowns.
Sure. All right, I have 3 more questions before I turn to the chat box again. First, related to your previous answer, through the years, I've read discussions in our Facebook group about TRT doses, and there are always some that say, yeah, I really need 300 milligrams a week, for example, to feel well, to get rid of all my symptoms. And there are always others that don't believe that. I say that's a bodybuilder's dose and so on. So what is your opinion? Have you had many patients on 300 milligrams and higher?
No. Long term, no. Very few. However, I do have retired bodybuilders as patients. So I do have some. I think, like when you ask what is a TRT dose, it's somewhere under 300 milligrams a week. That's probably the upper limit for extreme cases. For me, a TRT dose is a dose that can effectively change your body composition, assuming your lifestyle is not completely horrible and you never sleep, for example. Bad sleep and untreated sleep apnea, by the way, as a side note, is one thing that really decimates a lot of benefits of TRT, just so people understand. Not to mention maybe worsen certain side effects. But yeah, so I think it's somewhere under 300, but 300 is not a bodybuilder dose. I don't know any professional bodybuilder who uses as low as that. Typically it's much, much higher. And the guys that I treat, 300 is like a nothing dose, which there are going to be young people who listen. I'm not saying that it's good to take high dose of testosterone or any testosterone if you don't need it, especially if you're young. But I mean, 300 is not, that's not a dose that it would keep me up at night. Oh my gosh, this guy's on 300 a week. Is he going to drop dead any second? The guys that keep me up all night are the guys on much higher doses and plus a bunch of other things too. So,
yeah. What are some of the most common side effects you see on guys starting TRT? Is that high blood pressure, anxiety? I don't know.
The major side effects of TRT, number one, you can't really have this discussion without mentioning it, is infertility. Most men, especially on injectable testosterone, but even on compounded creams, their sperm counts will go way down. A lot of them will develop what's called azoospermia, meaning they won't have really, they'll be infertile, okay? Which is largely reversible, by the way, and treatable and preventable with other medications, but that is the most common side effect, is some degree of infertility. Another side effect is edema, or what we call water retention. The water retention that comes with testosterone and other androgens is quite annoying because from what I can tell, it's not always like a gravity dependent thing. So a lot of people, after they work all day, they notice their legs are swollen. They develop what's called pitting edema. So they press on their ankle bone, you'll see like an indentation, that's an indication of a lot of water in your extracellular space, so to speak. So testosterone can worsen that, but testosterone even can do things like bloat your face, make you get water retention in your face. And we don't know all the reasons why testosterone does that. If you look in textbooks, they'll mention a bunch of different mechanisms that have never been proven. But that is a symptom, a potential symptom. Cognitive symptoms, you asked about anxiety. The thing we see most commonly is what we would say is mood lability, which is not necessarily anxiety or depression, but moods that fluctuate rapidly. Okay. So that could mean for certain patients, they have much more anxiety. That could mean for some patients, they experience a degree of euphoria. Actually, both of those are side effects. It's not good to get either of them. But can it happen? It can, and it does happen. Sexual dysfunction can be a transient side effect of people starting testosterone. They can feel like their libido's lower, or that it's good some days, bad some days. That typically resolves after 3 months. Same with any transient erectile function issues. Increased red blood cells, if you want to call that a side effect, that obviously that happens in many patients. Acne definitely can be worsened by androgens. Testosterone can worsen sleep apnea too if it's untreated. it causes a component of central apnea. So actually, technically, it's unclear whether it actually worsens the obstructive component of the apnea, meaning how many times you have like hypopneic episodes where you don't fully breathe. You don't get a full oxygenated breath, I guess would be the way to say it. But it does cause a temporary worsening of your overall sleep architecture by causing a central sleep apnea component. And in 2 studies, that effect goes away after about, or is undetectable after about 18 months. And then the last thing is, well, there's 2 more things. Worsening male pattern hair loss. Never really been proven that testosterone worsens that. In theory, it could, though, because male pattern hair loss is, at least in very large part, a DHT-driven process. And remember, from testosterone, you get estradiol, you get DHT. So maybe by raising your DHT levels, that can worsen your hair loss. What I'll say is that some men actually grow hair on testosterone on their scalp. It's a minority, but some do. There's a very complex relationship between low testosterone and scalp levels of hormones, such that most men, I would say, won't really affect things like you're going to lose your hair anyway just because of your genetics if you don't do anything about it. Some men, maybe it accelerates it. Some actually grow hair, weirdly or not. The last thing is gynecomastia. Gynecomastia is where you get glandular breast tissue under your nipple, and specifically under your nipple. Usually it's a nodule that you can feel. It's like mobile, and it's often very painful too. So it's not like I have what I call bitch tits or whatever. It's a glandular breast tissue that you can feel, and it's like present there. You can even detect it on mammography or cut it out in surgery. So, and that's potential. Those are all the common side effects.
All right, interesting. One last question from me before we get to the questions. I guess you use some or you recommend some supplements in your patients starting out on TRT as well. So what's like the top 3 supplements you made them take?
There's
maybe
really
something
4
for the workouts as well.
Well, okay, yeah. So supplements. So I'm not a huge supplement guy. The
Okay.
first thing I recommend is like a complex B vitamin. I don't have any specific brand that I promote, but there's some evidence that androgens can increase your homocysteine levels. So B12 can help with that. And it's a super safe and super cheap supplement. So for me, that's one I recommend. Creatine monohydrate. It's effective, maybe even latest evidence, it might even improve your cognitive function if you use higher than 5 grams a day. I think at 10, maybe even higher than that. That's one of those things. Is it going to change your life if you start taking creatine? No, but beneficial, effective, I think. Another supplement that I recommend to some patients, particularly because I have a lot of obese guys, is a supplement called HMB, hydroxy beta methylbutyrate. And it's a supplement that reduces muscle protein breakdown while they're in a calorie deficit, which they usually are. So sometimes I'll recommend that. Maca root extract I'll recommend because it has proven effects on libido and sex drive. Sometimes L-carnitine I will prescribe actually to patients, specifically with metabolic syndrome. And why? Because there's evidence that L-carnitine can help with the what's called metabolic inflexibility. So when you have the obesity that I'm talking about, you usually have a dysfunction in your liver and fat cells. They develop metabolic inflexibility, which means they can't efficiently switch from burning sugar to burning fatty acids. It also happens in your testes, by the way, which is a huge problem because if you can't burn fatty acids, you can't make testosterone. So the L-carnitine actually it helps in the process of, alleviating the congestion in mitochondria. That's a very lay person's way of saying it. And the patients that benefit the most, I think, are the ones with very high C-reactive protein levels. So if you search L-carnitine, C-reactive protein metabolic syndrome, there's a few studies showing L-carnitine can help with that. But that's, as far as supplements go, that's pretty much it. And everything's cheap. And I don't sell anything any of those things directly. So beyond that, not many supplements that I would recommend. You asked me about peptides. So there are some patients that are interested in peptides, and I do sometimes use tesamorelin. It's been a while since I've used it, but tesamorelin does reduce your visceral fat. So, you know, and probably faster than testosterone does. There's some questions about how durable the effect of tesamorelin is. Like, for example, if you go off of it, do you regain what you lost? Some studies seem to suggest that, but yeah, that's as far as like ancillaries. And then obviously I use a lot of semaglutide, tirzepatide. I use that like crazy, but that's not a supplement. That would just be another drug. You know, Cialis we use like Cialis is virtually a supplement now. You know, I live a lot of times in Latin America, and you can just go buy Cialis over the counter. So if you consider Cialis a supplement, low dose Cialis is also very common, popular.
So that's 5 milligram tadalafil daily.
Yep. Very safe, beneficial, not only just for your erectile. Well, let's start with erectile function. It's very good because even if you have mild erectile dysfunction, it's very important not to ignore that, because the penile tissue, again, to put things in lay terms, I'm going to say it's a muscle. It's not a muscle, but if you just ignore it, it tends to get worse. So if you don't have strong erections regularly and you go that way for a long time, you know, you can actually worsen the dysfunction. So I think it's important to treat early. And the other thing is Cialis has other benefits. There's ergogenic benefits, meaning it can increase hyperemia to your skeletal muscle while you're working out. So that may have anabolic benefits. It has mitochondrial effects. So there's some evidence that it can, that it has certain anti-aging properties, things like that. So, and it's very safe. Very few people have side effects from low dose Cialis. And, I mean, I don't put everybody on it, you know, but if they even say they have a minor degree of ED, I think it's pretty slam dunk, especially now that it's so cheap too. Sure. And then HCG we use for fertility preservation. We didn't talk about that, but you know, that's another thing someone asks about it. We use a lot of HCG because that helps preserve your fertility in most cases. I mean, it's not 100% guarantee, but the vast majority of men who start injectable testosterone, who also take 500 IUs of HCG every other day, will maintain a fertility level of sperm counts. Maybe even some who use 250 every other day, at the risk of increasing side effects, of course. But
I guess most men over 40, 45, they don't care so much about fertility anymore.
They don't care about their fertility, but you know what some of them do care about is their testicular volume. So they don't like the fact that they get atrophy on the testosterone, or they're, put in lay terms, their balls shrink. So for those guys, yeah, I'll still give them HCG, like if it's really important to them. But most people don't care, you know. You know, we all care about different things, you know.
Yeah.
I always mess with my guy. I mean, are they really that smaller than they used to be? Yeah. But I give my guys a hard time. So
yeah, I don't care about that. I don't care about my hair that I lost way before TRT. So yeah.
Yeah, I mean, that's good. I'm fighting a losing battle, unfortunately, but it is what it is.
A
lot of guys look good bald. You're one of the guys that looks, you have a good face for baldness. I think if I was bald, I'd look like a creature from the Black Lagoon, but there are guys that can pull it off good. So you're one of them, maybe. So that's good.
Yeah. Anyway, you get used to it.
Yeah.
Yeah. Let me take just some questions from the chat box. How can you lower your cystatin C levels, and what number would be a problem?
So cystatin C, so that would be that's a measure of kidney function. Cystatin C is not a test that well, I guess I do order it somewhat commonly because I have patients with lots of muscle mass. What happens is when you get a regular blood test to look at your kidneys, you get what's called a creatinine number, okay, which is used to calculate how effective your kidneys are at filtering your blood. Problem is in patients, especially men who have high muscle mass, their creatinine can be high because muscle protein turnover can, cause your creatinine to be high. So we'll have young men who are otherwise healthy, but, buff, big guys, their creatinine's like 1.7, which would be really concerning for like a guy normally who's in his 20s or 30s, but it's because he has a lot of muscle mass. So how do we determine their real kidney function? We'd measure a cystatin C. Because cystatin C gives us a measure of, gives us an idea of how to calculate what's called your glomerular filtration rate without the interference of the protein, muscle protein turnover. And what's a high number? Yeah, I'd have to look at I think it'd be like 1.2, something like that. But the key thing with cystatin C is even if it's a little elevated, that's abnormal because it's not like creatinine where if it's elevated, then we have to do more further stuff. An elevated cystatin C is similar to an elevated troponin. It's abnormal if it's high. Something's going wrong if it's high. So that I'd say even just a little bit high is a reason at least to have it rechecked at minimum, but also have urine tests and, depending, you definitely see what your blood pressure is like. If you're on synthetic androgens, that's a huge problem because a lot of synthetic androgens can cause kidney issues. It's rare for TRT to do it, but I shouldn't say unheard of because I have seen one case of it. Yes, any elevation in cystatin C is problematic.
Yeah. Do you have some tips on how to use TRT accordingly for us night shift workers?
I don't see why it would be any different in night shift workers. People ask me all the time, like, okay, when is the right time to inject testosterone? And I say it should be the same time every day. People worry because they know, okay, my testosterone levels are normally going to be highest in the early morning. That's what my circadian rhythm dictates, that testosterone has what's called a diurnal pattern. It's low late at night, and then in the morning, as your cortisol levels are highest, your testosterone levels should be highest. So people think, okay, they're supposed to be highest in the morning, maybe that means I should inject myself in the morning. But it doesn't really matter because when we're giving someone exogenous testosterone, we are making their testosterone levels tonically high. So in other words, you're going to lose your normal rhythm pattern just being on testosterone. And this is the reason why some men who are on TRT, they say, I don't get morning erections anymore. Yeah, because part of what causes morning erections is your early morning diurnal testosterone surge, which we abolish with the exogenous testosterone. So the key isn't, I'm not having morning erections, is if you want to have an erection, can you have one? Well, yeah, I can. Well, okay, then don't worry too much about it, right? So for a night shift worker, it just matters that you inject at the same time every day, whether that be in the morning, whether that be in the evening. Because like I said, the difference between you, at least in terms of the testosterone, is hopefully you're going to have about the same pattern no matter what. There are other problems with shift work that you can't really avoid, but the timing of your TRT dose isn't something that I would worry about, just as long as it's consistent.
Related to that, I have seen discussions in the past about guys asking, wouldn't daily injecting testosterone propionate be better since we are mimicking the natural ups and downs?
No, because number one, daily testosterone propionate won't do that. You're still going to get a tonically elevated testosterone level above the level that, your body's use. It's not going to fluctuate in that sense. That's the first problem. The second problem, there's never, well, I guess if you're doing TESP daily intramuscularly, I mean, obviously that's been studied. But if you're doing like sub-Q daily, there's no studies on Test P used subcutaneously daily, so we can't say it's even effective for sure. Probably it is, but the big concern is that, again, it's the idea isn't to mimic your normal physiology. Daily injections of propionate aren't going to mimic your normal physiology, and you shouldn't assume that it's beneficial to do that anyway. I mean, your normal physiology is that your testosterone levels decrease.
Yeah.
They just go down.
Yeah.
So normal is not necessarily what we're aiming for, and unfortunately, all forms of exogenous testosterone are not going to mimic the way that your body produces testosterone. Like, a lot of people get pellets and they think, ooh, the pellet is going to be the most physiologic, and it's not. Even though it's something that releases testosterone, it does so constantly. It's not like your testes and your brain coordinate your levels to go like that.
Mhm.
Like boys going through puberty, their testosterone levels at night go like that. They can go up 8, 9 times what they are, and then in the morning they're back to very low. So that's the normal way your hormones work.
Yeah.
We don't want it to do that
Mhm.
medically, because that's, we want to change things. We want to biohack you. We want to make you a monster. No, I'm just kidding about
Exactly.
that.
Exactly. I had patients ask me in the past as well this question again and again. Yeah, but is that natural? Is that natural? I always say natural. Yeah, that's just not taking antibiotics when you have an infection. That is natural, and then then you die.
Exactly.
Yeah.
Exactly.
Um, can you explain how dopamine functions as a precursor to HGH?
Explain how dopamine functions as a precursor to HGH.
Yeah.
In the context of what, taking some kind of dopamine like drug to increase your HGH, or is he just asking a physiology question?
Yeah, I think it's a physiology question, really.
Um, I can't think of dopamine as a precursor to HGH because, no, I can't.
Okay, that's fair. Does HCG have the potential to increase sensitivity and increase ejaculate volume at 500 IUs a week?
Have the potential, yes. That dose, in as far as I can recall, has not been studied. So that might be too low of a dose. The doses that have been studied is 250 to 500 every other day, when you're talking about with injectable testosterone.
Yeah.
If you're talking about HCG alone or HCG with anything other than injectable, I don't know the answer, because it really hasn't been studied. But the minimum dose, I think, that's studied that we have good confidence that works is 250 every other day. So I'd be concerned about 500 working. But that being said, there are anecdotal examples I have of guys using like 1,000 a week, and they still have sperm counts. But I want to be very careful, because, having 4 or 5 patients like that doesn't mean is not as good as like a research study with like, hundreds of patients.
Very general question. Should you get on testosterone if your testosterone level is under 400?
It depends. Like, if you have metabolic disease and you are on weight loss drugs or thinking about it and you're obese, yeah, potentially testosterone can help you. Not everybody. See, the thing is, it shouldn't be just based on your level. It should also be taken into account what are your symptoms, and can the testosterone help or be estimated to help with those particular symptoms given your levels. So I'll give you 2 examples. So there are guys that have levels of 400, 450, 500, and they say, oh, well, my sex drive's lower than it was when I was 20, and they're like 50 or something like that. And that's their only concern. Let's say they have perfect body composition. And I'm going to say, well, I mean, the testosterone may or may not improve your sex drive. It may even make it worse. So it's a limited benefits. But if they're obese and they have pre-diabetes and they need to lose weight, then yes, it's very often it can help, or it should be at least considered. I've met guys, and I met a guy recently whose total testosterone level is like 270, and it's been that way for a decade. He has like 8% body fat, no diseases, but he does like cold plunges. He's like a junkie that he's like one of those cold junkies that does like those really ice bath like things every day.
Yeah, yeah.
And so I think that has something to do with it, because for example, I've encountered other patients with no symptoms of testosterone deficiency, but subnormal testosterone levels, who are otherwise perfectly healthy, lab wise, symptom wise, body composition wise. So it's not, it's never just based only on your level, which is a lot of doctors don't even understand that. What matters most is, can you be expected to benefit from it medically, not what is your level. And there's a lot of nuance that goes into determining that. There are even men with low levels that shouldn't be on testosterone. Okay, let's say, you're an 18-year-old who doesn't sleep and spends 8 hours in the gym. I've seen tons of these kids, and even in their 20s. Yeah, I'm in the gym 4 hours a day. How much do you sleep? Well, I work 60 hours a week, so I sleep 4 hours a night. Your testosterone level is 240. Should that kid be put on testosterone? Absolutely not. Absolutely not. Not when it's strictly your lifestyle and you're very young, meaning your duration dependent risk is highest. So yeah, it's an individualistic thing. Individualistic.
And also a general thought, if someone was low on testosterone, like whether it be 250 or 400, and he has no symptoms at all, could he still benefit from taking testosterone, like for health, for bones or mineral density or something like that?
I would say yes. Well, number one, yes. Testosterone has beneficial effects on body composition in virtually everybody, even people with so-called normal levels. So what happens when you age is, aging is kind of like an inflammatory disease. It causes you to lose muscle mass. It's called age-related sarcopenia, and it causes you to gain fat, including visceral fat. So I think patients with very low muscle mass, and patients, and especially if they also have, high amounts of visceral fat. So we see that sometimes there are non-obese patients with very high visceral fat. That's a silent killer. Those are the people that get cancer, that get diabetes. They're called skinny diabetics. There's an epidemic of skinny diabetics in India, for example, right now. And those are people with a lot of visceral fat, but technically their waist circumference doesn't meet the criteria for obesity, or their BMI is not very high. And I do think those patients can, in many cases, benefit. Yeah, I do. And that's the part of my practice that I like kind of specialize in, because any guy who's like 50, obese, and has a testosterone level of 200, I mean, even today, a lot of primary care doctors are not going to say you don't need testosterone. Some might, but okay, some might, but increasingly many won't. So I get a lot of the guys that, oh, my level's 400, my doctor checked it 3 times, but my BMI is like 42, and I'm about to have bariatric surgery, and their disease profile is a mess. So we're experts at using testosterone in those patients.
Yeah. All right. Okay, Chris. So we're already over an hour. So I would like to thank you so much for your time and knowledge. Before we wrap this up, how could people reach you if they want to work with you?
Sure. So our website is b3clinic.com, b3clinic.com. It's just a patient interest form. People are like, why don't you have a full website? I almost have a full patient panel, so it's kind of like, why even bother at this point? But I'm also on TikTok, C Bronson MD, and C Bronson, and the same on X, and I'm pretty much C Bronson MD on YouTube as well, and then C Bronson MD on Instagram. All right. TikTok has most of my videos, sadly, but we're gonna hopefully change that.
I'll check all of those out. Thank you so much.
Well, thank you. Yeah, thank you for having me. I really appreciate it. Appreciate your audience, and yeah, hope to talk again soon.
Yeah, you're very welcome. Thank you so much. And for
Thank you.
everyone still watching, thank you for following along, and give this video a thumbs up, and see you next time. Bye-bye.
Bye-bye.
Bye.